So we're going to talk now about preventing and managing pressure ulcers. So prevention, first of all, we want to identify patients that are at risk, but we want to protect their skin. We want to keep skin clean, dry, and intact. We want to have patients on a firm, wrinkle-free mattress or chair with wrinkle-free linens. A fold under the patient can actually cause a pressure ulcer. We want to reposition patients at least every 2 hours in bed or 1 hour in the chair. Some clients may actually need more frequent repositioning. We need to keep the head of bed at or below 30 degrees unless it's contraindicated. Because when we have them sitting straight up in bed, it's kind of concentrating all of their weight down on their sacrum, and so we can have sacral wounds. Float heels. Those heel booty things, they're made of either lamb's wool or they're stuffed. They're like stitched stuffed. Those are not effective. They actually can continue to put pressure on the heel. A much better method of protecting heels from breakdown is to float them on a pillow. So if you have a patient that is bedbound, put a pillow underneath the calf. You want to make sure that it's long ways, usually so that it's not leaving part of the calf dangling in the air. We want to support the knee joint, but you want to have their heels off the bed just a bit. We want patients to be getting out of bed if they're able, ambulate early and often. That improves circulation and gets the pressure off of those bony prominences. We want to instruct a client who's able to do so to shift their weight about every 15 minutes. And clients who have decreased sensation, if we tell them maybe use a visual cue, every time a commercial comes on TV, shift your weight in the chair, that can help. We want to prevent patients sliding down in bed, and we want to lift rather than pull the client up in the bed or chair. So don't drag them and drag their skin off. There are supportive devices. There are mattress overlays to reduce the pressure. There are also special mattresses. Some of those mattresses have air cells that inflate and they change pressure, so the air pressure in each cell changes, so that's constantly changing the pressure. The most advanced is an air fluidized mattress or part of a mattress. An air fluidized mattress, there's a bunch of little tiny beads, like I think they're styrofoam, I don't know, they're really tiny, and they're all contained within this mattress, and it has a permanently attached sheet, and air is forced into the container for all of those beads. So the patient is resting on this bed of little foam beads that's constantly shifting in pressure. It's an air fluidized mattress. They have, like I said, full mattresses that are air fluidized, and then they have partial insets in the bed. Skin hygiene, we want to inspect skin frequently, use mild cleaning agents and pat it dry, use moisture barriers for incontinent clients. Powder and cornstarch are not helpful. They tend to be abrasive to the skin, so they can cause more skin breakdown. They're also an aspiration risk, so don't powder and cornstarch. We can teach patients active or passive exercises to shift their weight and increase blood flow. Don't massage bony prominences. So we don't want to massage those heels. We can increase the damage. For nutrition, make sure that patient's getting enough hydration, enough protein, enough calories. If their serum albumin is low, they're going to need a protein supplement. They may need vitamin and mineral supplements as well. If a patient is not eating well, sometimes we offer supplement shakes, but if we offer those at mealtime, they'll consume that instead of their meal. So instead, offer those shake supplements between meals to try to increase their overall intake. Or if they refuse a meal, offer the shake as a substitute. Treatment of pressure ulcers. For suspected deep tissue injury or stage 1 ulcers, either one of those, we want to relieve the pressure, encourage frequent repositioning, provide pressure relieving devices and surfaces, and we want to keep them dry, clean, and well nourished and hydrated, and hopefully allow that to heal. For stage 2, this is a blister or open skin, but it is shallow. We want to maintain a moist healing environment, so they need saline or they need an occlusive dressing that maintains moisture. They need nutritional supplements to promote healing. And stage 2 wounds tend to hurt, so we need to relieve pain. Stage 3, if there is slough in that wound, the fibrin deposits it's kind of the gray yellow color, it's strange colored. They need to be debrided. A provider may do surgical debridement. There are also dressings that promote autolytic debridement, and there are actually enzymes that can be placed in a wound bed to debride it. We've got to be really careful when we're placing those things that we're putting them on the tissue that needs debridement. Nutritional supplements to promote healing. So we want to make sure we're getting plenty of protein and vitamins. Pain management, and usually this wound is going to be either infected or is at high risk because they probably need antibiotics, or they may need something antimicrobial in the wound. Once it's debrided, we want to protect and maintain a moist wound bed to allow that wound to heal. So if there's space in the wound, it needs to be filled with something. So we need some kind of filler, and then we want to maintain a moist wound bed. Stage 4 wounds are very deep. They affect bone. They can affect bone and underlying tissue. They may need to be debrided. Usually they do have a lot of slough or even eschar. Again, the same methods of debridement. A non-adherent dressing can be placed. It should be changed every 12 hours. They need nutritional supplements, pain management. They need antimicrobial things inside that wound. Once it's debrided, we need to protect it, keep that empty space filled, keep the wound bed moist. Stage 4 wounds sometimes require hyperbaric therapy or skin grafts. A wound that is covered with eschar is unstageable, and it has to be debrided, and then it is staged and treated accordingly. Frequently, providers will order things like alcohol to a wound, Dakin solution, hydrogen peroxide, betadine. All of those things are cytotoxic. They damage healthy cells. Now, some of them have antimicrobial properties, and that's the thought process. We're going to kill the bacteria so the wound heals, but they will also damage healthy skin. So we want to avoid those solutions. Complications of pressure ulcers. They can deteriorate to a higher stage ulcer. So we need to make sure they're being assessed regularly, and if they're getting worse, they need to be reported. We also need to make sure that the facility protocol is being followed, because frequently it isn't. Wound care is not always done. It's not always done properly. It's not always done consistently. And if a wound is being treated as ordered and it's not getting better, they need to be referred to a wound care specialist. Infection is a risk of pressure ulcers. We need to be monitoring wounds for increased exudate, odor, and other signs of infection. Maintain aseptic techniques. We need to use at least clean technique when changing those dressings, and report any signs of infection. If a wound becomes infected, the patient can become septic. So we need to monitor our patient for signs of sepsis. Increased temp, increased white count, increased respiratory and heart rate, hypotension, oliguria. So again, to prevent that, we want to prevent the infection in the first place. We want to recognize and treat wound infections early, optimal nutrition, and adequate rest. All right, so that's integumentary. And we have 2 other lectures in these series, elimination and mobility.